My name is Mervat. I am a consultant of pelvic floor rehabilitation. I'm from the country of history and pyramids, Egypt. I took a long distance and time to come here and present a major important topic related to our conference, the second edition of a conference of women health and gynecology. I'm talking today about pelvic floor because it's a hidden topic in my country. I have the first pelvic floor rehabilitation two centers in Alexandria and in Cairo, in Egypt. And after my stay and training and working in Germany for about 6 years, I found that this is a very important topic, which is what's not in a focus in our country. And it's very, very common because of multiparity for the women, bad dietary habits, many pelvic surgeries. So I will tell you today about obstructed defecation, especially in elderly women. And the role of pelvic floor rehabilitation in those women. According to functional constipation, what is obstructive defecation? It's not a type of organic constipation. It's a type of functional bowel disorders. It means that the patient is unable to defecate in spite of soft motion. It's soft stool, but the patient is unable to defecate. And it's very difficult and it's not understood by many professors in internal medicine. They know any the diagnosis of this condition. They think that it is the normal organic constipation. According to the conditions, we have many cases, but it's a taboo. We don't know. We don't have how many patients, but there are many in my clinic. I have also from the world, from Saudi Arabia, from Bahrain, Qatar, many countries. What is the difference between normal and the obstructive defecation? In normal defecation, there are important muscle, which is puborectalis. It's important muscle, which is making an important anorectal angle to prevent the patient from incontinence. And when the patient defecates, there must be relaxation in this muscle. So the anorectal angle will be straight, and the patient, the normal person, will defecate a large amount without any effort, without pain, and he feels relaxed. According to our topic, we're talking about obstructive defecation, which means that there's anesmus. What is anesmus? It's a sort of paradoxical contraction of the muscle in spite of relaxation during straining and defecation. And the pudendal nerve is an important nerve which is playing an important role in this condition to give the sensation, to give the motor relaxation and the autonomic sensation and connections to help the patient to defecate with a good power of pelvic floor muscles, which is supported. There's no prolapse, there's no rectal descent, though the patient can defecate in a highly integrated manner with a proper defecation without any pain, without effort, and without any laxatives, and in a limited time. According to the pathogenesis of this condition, the pathogenesis is multifactorial. There's alterations in the pelvic muscles physiology with a normal impairment in the nerves. The presentations is not only related to the bowel, not related. It can end in fecal incontinence, as if overflow fecal incontinence, patients who cannot defecate for about 1 and 2 and 3 weeks. And there's an overflow fecal incontinence. And I can see these conditions also in children in my country. Or the severe obstruction, the patient cannot defecate. There's no role, difficult to do the surgeries to these patients because there are severe rectal prolapse and descent, and sometimes with colostomy. Bladder is also affected by this condition because when there's obstruction and descent of the bowel, there's also compression on the bowel and the bladder, and there's also descent that patients suffer from retention or also from weakness in the pelvic floor muscles, which can lead to urinary incontinence and sexual disorders. Many women in our country are suffering from dyspareunia, and the gynecologists cannot recognize that the problem is physiologic due to problem in the pelvic floor. We have rectocele and cystocele, which is causing narrowing, and these patients are falsely diagnosed as conditions of vaginismus, that there's a spasm in the vagina and there's narrowing due to rectocele and cystocele due to descent of the pelvic floor. And we have also conditions with pain, which can lead like vulvodynia, like proctalgia, if you have severe pain in the anus, and they can be diagnosed as a psychological condition, and there's a problem in the nerve, perennial neuralgia, which results from this severe descent. According to the program of the rehabilitation, start with diagnosis, which is very important, assessment, and then about health education, because it's a new type of therapy in our country, and exercises, which is very important because it's active exercises. And my role is the pelvic floor rehabilitation through devices, which I will tell you different physical modalities. Diagnosis is very important. I have to ask about the history, and it must be full history taking, not only asking about the bowel, about how many times you bowel, the time, usage of laxatives, the feel of comfort, abdominal distension, about pain, bleeding during defecation, for example. We also ask about the very important if the patient have desire to defecate or not, because these patients, not like organic constipation, they have the desire and they go to the toilet, but they are unable to defecate, or they defecate very small amounts of stool. Or there are conditions about related to also the urinary condition. We ask about urinary incontinence, if they are using bowel, about urge, because these conditions can lead also to urethral hypermobility or overactive bladder. We ask about the sexual condition, about also pain. About examination, also, I will tell you important topic related to my specialty. Laboratory is important when I'm talking about bowel problems, maybe fecal carpoprotectin. We have many cases of Crohn's disease and ulcerative colitis due to this obstructed defecation. According to the laparoscopic investigation can be unhelped, and very, very important MRI diagnostic, dynamic pelvic floor MRI, where we can see the pelvic floor during rest and during defecation, during straining, and we can see the perineum descent, rectocele, cystocele, megacolon, biles. When there's fissure, we can see also the uterus, the ovaries. All of these conditions can be seen in this very important MRI. According to my role, is to assess if the patient able to isolate pelvic floor muscles contractions or not. Can the patient do align the contraction, or use accessory muscles like